Hi, Ann. This is Kalyani Rajeshwaran from my IT department in Amar, Seva, Sangam. I am very glad to welcome you all for this wonderful webinar, the Transdisciplinary Approach Successful Early Intervention webinar. Here we are having a very good two speakers, Ms. Brien and Franzina Coutinho. Brien is an Associate Research and Capacity Building Director in Amar, Seva, Sangam. And also she is a pediatric physician, pediatric physiotherapist and a clinical researcher in Canada. And she has presented many international conferences and published many journals in that peer-reviewed. And Franzina Coutinho is a pediatric occupational therapist, and she is a research director in Amar Seva Sangam. And she is a clinical researcher based in Mumbai. And also she is an affiliate member at McGill University. Ma'am, I am welcome you both. Can you please start that webinar?
Thank you, Kalyani.
Thank you, Kalyani.
Good morning, everyone, and welcome to our first webinar for the year. Greetings from Amar Seva Sangam. The topic for today is crossing barriers, the transdisciplinary approach to successful early intervention. Okay. So this is the Rangoli outside Amar Seva Sangam that is basically used to welcome everybody that comes to the center. I haven't been fortunate enough due to COVID to visit yet, but I'm hoping that's something that happens in the near future. So the aims of today's presentation, right? Yeah, my PowerPoint seems to be all over the place. The aims of today's presentation are fairly straightforward. We know that there are a variety of models available in the literature as far as pediatric interventions are concerned. But the one we're trying to highlight today is the transdisciplinary approach. Through today's presentation, we are hoping you're more aware of what that means. You understand the essential elements of what this approach consists of, the benefits and the challenges in having such a team, because they do exist. And how do you create such, a transdisciplinary team for early intervention in resource limited settings, right? When you have very little to go with. We're going to share the ASA experience with you and the enabling inclusion model that we follow at our center. So as you can see in this PowerPoint, we have individual disciplines working together on a client or a patient, doing our own thing, and then it evolves to 2 or 3 professions: speech therapy, occupational therapy, special education, psychology coming together. You then have them overlapping a little bit and doing some work together. But this is the epitome of what we want for client-centered care to look like. We want the child to be the focus and there to be a blurring of lines so that a child is getting the best possible services. Okay, so now what is the transdisciplinary approach in child rehab, right? These are services defined by sharing roles across disciplinary boundaries. So there's a blurring of lines, there's open communication, there's interaction between therapists, special educators, psychologists, and the patient. And cooperation is maximized among the team members, parent being the center of the team, right? The parent of the child being the center of the team. Yeah. So just remember that transdisciplinary rehab approach is basically family centered. Okay. We have one therapist that assumes the lead therapist role. I'm going to talk to you a little more with examples about what this is and what it looks like. The lead uses coaching as the key. So what this means is your primary therapist will train the parent as to how to implement a program at home within the environment that they are comfortable with to encourage maximum utilization of opportunity presented within the environment, right? So the end game is always integration within their environment, and that's what we are hoping to do through this approach. All right, so this is a very important slide. And what we're going to do here is look at the traditional approach first and what we hope will evolve and become, or what we want a transdisciplinary approach to look like, right? So in India, right, all of our interventions are professional centered. So what that means is a child comes in to a therapy center, will probably see the doctor, be referred for OT, physio, special ed, speech therapy, psychological assessments. We identify what the possible deficits might be, right? We create our assessment plan, and then we provide solutions or interventions to treat the problem, right? So it's the remediation of a disorder or the problem. And the professional is considered the expert. So it's fairly patriarchal, where we assume that what we know and what we understand is the best possible level, and the client or the patient has to basically listen to us and follow on what needs to be done, right? However, when we look at a transdisciplinary approach, what we're looking at is having it client-centered or family-centered. So the child will come in, you will sit down as a team, you will interact with the parent, you will identify strengths that the child might have and empower the parent. And this is not something that happens overnight, right? This is a series of interventions that we're looking at over a period of time. And we try and create a solution or plan based on resources available, right? And we optimize performance based on their skill set, based on what the child's skill set is, based on what the parent's skill set is. And we're going to give you concrete examples as we go through today. The professionals are not the end all or the all-knowing. They basically are facilitators, right? You all are the support system that encourage the parent, who is the actor or the primary person in the spotlight, who is going to, we are going to figure out the best way for them to execute the intervention at home. Okay. Now this is a visualization of what a typical, transdisciplinary team might look like. You have the child and family here at the center, right? And you have all the therapists or the specialists around, and they are basically trying to figure out the best ways of serving the client, including them being at the center of this entire operation, right? Right. So what I showed you before was at an individual level, okay? The transdisciplinary approach has basically superseded individual levels and has now moved to population levels. Let me explain what I mean. In the United Kingdom last year, this article was published last year, they identified children with autism, with a neurodevelopmental disability, CP and autism primarily, who had feeding difficulties, all right? They sent out surveys to 3 groups. One was parent groups, the other was professionals like special speech, OT, physio, special educators, and the third group was professional education specialists. And they identified in each group what were the most commonly seen problems and what were the best interventions, all right? They then did focus groups with smaller components to identify solutions for this. All right. And this is a template that professionals are now, they're hoping, it's a toolkit that's been created, right? So these are 15 different components that parents, especially the professionals and the specialists have identified together as being problem. I'm having a problem with positioning. I click on this, right? And there are 25 different types of interventions that come up that the parent can implement at home that has been been created already, right? So whether I'm an OT or a special educator or a physio going to the home, there is a toolkit that's already been created to provide to the parent. And this is parents across the country. Similarly, if there is oral and sensory desensitization, that's a problem. They're hypersensitive to textures and they're not eating appropriately. The parent tells me this is a problem, right? And then whichever the specialist is, whoever the lead therapist is, can provide a series of interventions or specialized therapy to this child based on what they've identified as the problem. Now, this is at a population level. This is at a population level where transdisciplinary approach has been used for everybody or can be used for everybody within the population. All right. So it's transcended just the individual and moved on to the entire population. So this is the power of what a transdisciplinary approach can be. Okay, so what are the benefits, right? It prevents fragmentation of services, right? So it means that if I'm going from OT to speech therapy to special education to physiotherapy, there is no break in the type of therapy the child is receiving. There is no duplication of services. So my physio colleague and I are not replicating the same services, but utilizing our time to provide best possible 45 minutes of intervention if that's the time that we're providing services for. The child is viewed as a whole, right? So there's no impairment, disability, oh, can't do this. You're looking at the patient or the client as a whole. It promotes therapy and intervention that is integrated in normal routine, right? So we are encouraging parents to do interventions within environments that are normal to them, which are natural to them, which are most familiar. So the chance of success is highest within an environment that's comfortable to them. And it also emphasizes the importance of having or seeing the family as an equal or probably the most important component in creating goals and providing treatment for their child. Okay, so let's talk a little bit about why this approach might be important in the Indian context. So currently we have about 53 million children under 5, right, that have a developmental disability, and 95% of these children are in middle or low income countries. India is one such country, all right? And what recent stats have shown is that there are 2.3 million children under the age of 6 with a developmental disability, okay? And a vast majority of these children live in rural or in semi-urban areas. So not in places where they're going to get easy access to specialized care. In India, we have a population of 1.39 billion. This is population across the board, right? So for our population, what statistics in 21 have shown is that we have 120,000 special educators that are registered, 50,000 physiotherapists that are registered, 6,000 registered OTs, 6,000, and 3,000 registered speech therapists, right? Even if you consider that all like these numbers are doubled, given our population, there is a dearth or very few, the ratio is disproportionate, right? And this is the number for all types, for geriatric, for mental health, for pediatric, for every type of problem you can think of. This is the limited number of resources available, right? So this approach becomes even more important because we can't waste what little resources we do have in duplication and fragmentation of services. Now, looking at these stats, it wasn't difficult, right? Now, this is in 2016, which is even before these stats came out. Then less than 10% of Indian children with disability were accurately getting diagnosed, and in addition, getting services provided to them, right? So it's a very small fraction of kids who do need services that are getting services to everybody. So how does this work, right? How does this work? As in, how does the transdisciplinary approach work? I'm going to tell you about that in a minute. First, what we look at is identifying various factors that are important. Okay, first is the family factors. Here we look at what's important to the family in terms of goal setting. What are the dynamics? It could be, the father being the caregiver, the mother being the breadwinner. It could be typically the other way around. What other family dynamics? Are there grandparents involved? Is the child the only child? So handling children is not as familiar to them. What kind of a schedule does the child have? Then we look at the child factors, right? This is what is the diagnosis or needs of the child. Is it attention? Is it motor? Is it sensory? Is it a combination of everything? And even in that combination, which appears to be the most important, according to you as a therapist, and then speaking to the parent, right? It's a combination of both these things. We look at the primary location where the child is situated and what are motivators for the child. So, for example, if you have a child who is 2 years old but has a motor delay and they want to explore the environment but can't, that movement is essential. So we figure out a way to get that accomplished. It might not be easy. That's not what I'm saying, but that could be possibly used as a motivator. Okay, you have a child who is on the spectrum who loves cars. That could be used as a motivator. I'm not saying only play with cars, but there is a happy medium where you can use toys effectively in intervention to help get better performance, right? We then look at environmental factors. Now, what this means is, what is their daily setting? What does it look like? Is there safety? Is everything appropriately set up? What is the distance for them in terms of getting services provided? And finally, we look at provider factors as a therapist, right? What is the relationship with the family? What expertise is available? And what is the availability? Like you might have OTC, special education, but only special educator available, right? So then what? How do we work around this? You then select a lead or primary therapist. I will be giving you examples and talking about this in a little bit. Okay, so like I said, let's talk about these two cases. Case one is Ajay and case two is Seema. Okay, before I go ahead, just to let you know, I don't think I announced it at the beginning. If you do have questions, please put them in the chat box. The moderators will compile a list and we will try to answer them if we have time at the end of session today. All right?
Yes, ma'am. Somebody is asked to go little slow.
To go slow? All
yes.
right. Yes.
And also somebody asked whether we can share this soft copy or not.
Yeah, so we will discuss that at the
end of the session.
Okay, can you hear me? Yes?
Yes, now.
Yes, all right. So the first case is Ajay. Okay, he is 3 years old and he has a global delay. Now let's look at some of the parent concerns, right? He doesn't sit in one place. He's constantly jumping. He's walking on his toes and he has difficulty sitting and climbing stairs or walking for long distances. He gets tired. So what other things do we know about this child? He's the first child in his family and he lives with his parents or grandparents. All right, so this is the first case. Now let's look at case number 2, which is Seema. She's 18 months old. She has a she has GDD as well. And the parent concerns are primarily that she cannot sit independently. She can sit independently, but she can't bring anything to midline. So she has no midline orientation yet. And she hasn't started standing. She has social smile. She points, but she throws things because she doesn't appear to have language yet, right? She lives at home with her parents and has an older sibling. Now, the first thing that you're going to try and do is look at the family factors, the child factors, the environmental factors, and the provider factors. So this is what you have. Okay, let's look a little more at the model. How would we implement this, right? first we'd look, initially what would happen would be the child would come in with their parents, okay? Everybody would sit down, whoever's in your team would sit down with the parent and the child. You would interview the parent about, background, case history, what happened, how did it happen, and figure out what their goals are, okay? In terms of a formalized assessment, you could do this at a later point of time in case you run out of time, but you decide if you can discuss, you have to discuss this with the parent, okay? Based on what the primary requirements are, okay, you select the lead therapist. So if it is more sensory, there could be an OT considered as the lead therapist. If it is motor, these are suggestions, okay, that I'm giving you right now. You could have the physio as the lead therapist. If you have speech, you could have the speech therapist considered as the primary, right? And if you have poor cognition and academic skills, you could have the special educator. You then look at knowledge exchange, right? Now, when I say knowledge exchange, it is exchange of knowledge to the parent of the child and exchange of knowledge between peers. So between the group of therapists working together, there needs to be a discussion about the child. I know this seems like a lot of work, but as you do it, it becomes spontaneous and more effective and faster. Okay. So this is something that you'd have to work at initially for it to become more effective later. Okay, so when we look at the other steps, right? Role release. My colleague Marie and I were having a discussion earlier, and both of us have practiced in multiple setups across the world. And I think one of the most difficult factors has been this. Role release is, as an OT, letting go of what I do, thinking that I'm the most important, and allowing my colleague to basically take over as the lead therapist, or vice versa, right? So letting go of your identity or professionally what you know best is difficult, but that with practice is for the greater good of the client. So I'll talk about that as well. Step 6 is intervention. So you create your treatment plan, and step 7 is reviewing and resetting of goals. Okay, so the first piece would be like we said, right? When we were talking about Ajay, there seemed to be a lot of sensory issues present there. There seemed to be a lot of hyperactivity, inattention, jumping all over the place, toe walking. So the first step, like I said, is figuring out the lead therapist, right? So in this case, we might consider an OT if there is an occupational therapist available as being the lead therapist. Because that might be the least amount of knowledge translation required among peers and most effective translation of information required for the child or parents of the child. Okay, knowledge translation and discussion among all the relevant disciplines is very important, because you might do what you do best, but if you have a child with a motor difficulties who also has some sensory issues and is inattentive, for example, right, you might want to improve attention a little bit in addition to doing all the other motor component, working on all the other motor components. Let's look at Seva. So she has gross motor and fine motor delays. The team, so she was assessed by OT and physio, and both have identified core and trunk difficulties as being the primary, trunk stability as being the primary area for intervention using appropriate therapies, right? Now you need to translate this information to the parents, saying, this is an example that I'm giving you, until your child has better core or trunk strength, they won't be able to walk effectively, and they won't be able to use their hands for other things like feeding and reaching out for things effectively as well, right? So as the primary or lead therapist, you have to convince the parent, and then between the OT and the physio, you two together have to figure out the best strategies to work on with the child. Okay, so a few years ago, my team at Hinduja basically conducted research where we looked at what parameters, it was a survey sent out to 78 parents to identify what parameters were responsible for having a good home plan, right? And these are the two things that we looked at: adherence to frequency per week. So that would mean if I said, I want you to do therapy 3 times a week for 20 minutes is the duration. Okay, 20 minutes each session is the duration, and the frequency is 3 times a week. I'm just giving you a random example. So having videos with your advice. So say, we are working on core strength or trunk stability, providing videos to your parent of how to do the work at home will increase compliance, which means it will allow your family to be 1.5 times, or to do this 1.5 times more or more effectively than if they didn't have the video. Integrating it integrating your home program in daily routines would have your parent double their compliance. Okay, so what this means is, if you have a child diagnosed with cerebral palsy with weakness on the left side, and you tell the parent, I want strengthening to happen, I want left hand use to be increased. When the child is bathing, when you're using the bucket and your water, see that he's using his left hand, hold down the right hand and see that he lifts the water and pours it on his head with the left hand. Okay, so what's happening over here is you're seeing strengthening, you're seeing range, you're seeing mobility, you're seeing mid-range, and the parent is doubly more likely, is 2 times more likely to implement the home plan. Okay, similarly in terms of duration, 20 minutes, they find it easier or more effective. They'll do it thrice. The odds of doing it is 3 times more. If it fits their daily routine, like I said, like I gave you the example of the bathing. And the most effective thing they found was using the child as a model, right? Showing how it would be done on their child and taking a video of that is the most effective piece for parents. And this is something that we did with Indian parents, right, based in Mumbai. So another piece, like I said, the most difficult or important piece is role release. So Ajay has sensory and motor difficulties based on what we looked at, and the OT takes over as a lead based on parent and child factors because of the sensory need that the child might have. So when we look at role release, right, there's a very vicious cycle where, not vicious, vicious as in it's a continuous circle basically, where as one therapist, I educate the entire team on what my specialty areas are and give simple strategies to identify, to execute, and to check. Okay, so these are the 3 components you need to have in place to see that your colleague or peer is effectively implementing simple strategies for their or your client as a group together. Okay, so this specific article was basically done last year as well, where they looked at teenagers with diabetes, and they developed a cross-discipline training program. Okay, so they had physicians, they had dietitians, they had psychologists, and they had psychiatrists on board, and all were trained the same way about diabetes type 1. Okay, and they found that when they did this, compliance, they had 2 groups, compliance in children who were treated by this particular group of people outperformed every other group by 40%. Okay, the transdisciplinary curriculum. So there is literature that's coming out now showing the very high and impactful information provided by these transdisciplinary cares groups. Okay, so a couple more slides. Now, like I said, there are challenges for service providers, right? There are professional issues that might come up, personal and interpersonal challenges that you as service providers will have to deal with. There might be a feeling of the loss of professional identity when you release the role. For that, you need to be extremely comfortable knowing what you do and that nobody can replicate what's needed, right? We keep on saying that the number of people who need help is tremendous as long as there are people to serve the community, which we don't have. You're never going to lose your role or identity as a professional. Liability implications. So there could be a fear of negligent behavior due to lack of insufficient supervision. Okay. So like I said earlier, you need to be extremely careful over here, and you need to pay attention to proper peer training among, when I say peer training, I mean your OT, special educators, physiotherapists, psychologists have to be on the same page. And there could be inadequate sharing of knowledge and roles due to experience of threat, right? Again, this is role release and the possibility of not having your identity that comes up again. So I think growth together is the best way to deal with that. Okay, so you might also face a problem with assigning the lead therapist. This will get easier this will get easier over time as you practice it more. Knowledge translation is also simultaneous crossing of boundaries and implementation of with you training the parent and simultaneously getting trained by your peers. Difficulty of role release or your identity, and cultural factors, which is also something we haven't talked about too much. But for example, if the father comes for the assessment but the mother's primary caretaker or vice versa, that could be one thing. The second is if there's an only child in the family, if this child is the only child in the family, or third, if there is there could be a very specific to a location things that are cultural that you haven't identified before. I will come back to you at the end of the presentation to talk to you a little bit and wrap this up, but my colleague will continue. Marie, over to you.
Thank you, Franzina. So now we're going to apply the principles of transdisciplinary care that Franzina has covered to the Amar Seva Sangam experience. And I'm right now in Canada, and I have worked in cities in Canada, and I've worked in rural areas in Canada. And I've also worked in Bhutan, and I've worked in South India. So I have seen both the urban setting and the rural setting in different countries. And I have worked in multidisciplinary settings and also in transdisciplinary settings. So it's interesting perspective to see how transdisciplinary care can be applied anywhere you are around the world with the resources that you have. So we're going to now go over how it was applied over time at Amar Seva Sangam and within the Enabling Inclusion Program. So looking at who do we serve at Amar Seva, looking at the pediatric side and the Enabling Inclusion Program. So just a glimpse at the children that we serve. Some may have developmental delays that they will catch up over time. Some have definite diagnoses of cerebral palsy, spina bifida, and maybe orthopedic conditions, muscular dystrophy. So we see children from ages 0 to 10. Well, it was 0 to 6. We expanded 0 to 10. And now we have expanded our Enabling Inclusion Program to cover to age 18. So just we see children with communication difficulties, motor impairments. It could be children with vision or hearing impairments, So the whole range of conditions. Sorry, okay. All right, so to develop the program at Amar, Seva, Sangam and enabling inclusion, we looked at what best practice were for developmental intervention. So let's just go over best practices. Sorry, I have difficulty with the controls. Okay. All right, so one best practice for developmental intervention is that the child must be learning in what is considered a natural environment. So it has to be within the context of typical daily routines. And we also talk about enriched environments. So the best place to have early intervention is actually within the child's home, because it is their typical environment. And then we also talk about enriched environment, that we really want to try to provide as much input to enriching all aspects of the developmental stimulation for the child within their own home. Let's look at another best practice. It's the caregiver's coaching strategy. So the emphasis should be on capacity building of parents to support their child's everyday developmental skills. And that's what we do with the Enabling Inclusion program, is that we coach the caregivers. So the therapists and the CRW use the coaching approach to train the parents to themselves be able to help their child to promote developmental skills on a daily basis within the daily routine. The other best practice approach is the family-centered care. So that's where we have the parents identify their own priorities and goals for their children. And we also provide coordinated and collaborative care as a team. We share information with families, and we're also culturally sensitive. So that's another best practice that we have put into application. And another one is nurturing care. Nurturing care is supporting the family's ability to interact with their child and to meet the overall needs of their child for optimal child development. So those are 4 different best practices in developmental intervention that we're able to provide by going into the child's own home and the approach that we take within the Enabling Inclusion program. So if we look at then building effective transdisciplinary teams, which is how we gradually and over time develop that transdisciplinary approach, because years back it was more multidisciplinary, where each discipline would work more of a separate entity, and now it has become transdisciplinary. So we have looked first to see if the team that our teams include members from multiple disciplines. So this we have. Then we look at to see that teams meet on a regular basis to discuss the children on their caseload, and they do. That team members cross discipline boundaries. So they each provide support and knowledge sharing to each other, and they do. We have one team member serves as the lead for the family. And that has been more recently that now we have what we call the primary therapist, where the primary therapist, as Franzina has explained, maybe if the child has a primary motor impairment, for example, cerebral palsy, it will be a physiotherapist who will be the primary therapist. If the child has a primary intellectual disability, it will be a special educator who's a primary therapist. If the child has a primary speech speech or communication impairment, it will be a speech trainer. So various types of, we have certain guidelines that will tell us who the lead will be for the family. And of course, there are other criteria as well. So we do have the functioning as the lead. And parents are an integral part of the team, and they set the priorities and the goals for their children. So that's one. So the team works together to pool their knowledge, skills, and resources. So teams are really cohesive. And I'll show you how our teams work. So that's there. And joint visits are encouraged. So we will have joint visits of key team members to visit the families and to train the CRWs, because our therapists use a train-the-trainer approach to train the community rehab workers. And the community rehab workers are able to implement the programs with the parents and coach the parents. And lastly, our services are individualized for families. We use the coaching approach and empowerment of the caregivers, yes. And lastly, all members share the responsibility for implementation of goals and the intervention plan. So check. So if we look at those are the key criteria for transdisciplinary teams, we can say that I've gone through them, I've checked them, and we do follow that approach. And while being in a rural area and where resources are limited, we are able to achieve that transdisciplinary approach. So this is an example how it may be used for a child who has cerebral palsy. Of course, we have our multidisciplinary team. So we have the multidisciplinary team, where therapists will do some assessments that are discipline-specific assessments. There's interdisciplinarity, where they do share knowledge. And then there's the transdisciplinary, where they take on the role of the others through knowledge sharing. And we do have the primary therapist model. And if you look at the child functions within the family. So the family-centered care is really encompasses the full spectrum of the child's development. So we have the child within the family and within the community. So that's a concept that is very important in child development, as child within family and within community, because we have to consider that the child is within their full community and environment. And that's why we use the ICF in guiding us in the assessments, the International Classification for Function, Disability, and Health. And the environment is so important to achieve our goals. So again, this represents well our enabling inclusion model. So if we look at a typical team per block in the enabling inclusion program, right now we are covering, there may be some differences, but approximately 31 blocks in 3 districts of Tamil Nadu, and we have 7 licensed NGOs within India, within 3 different states of India, in Assam, West Bengal, and Uttar Pradesh. So this is a typical team per block, where we will have in one block 3 community rehab workers, or CRWs, and we will have 1 specialist team that's composed of a physiotherapist, a special educator, and a speech trainer. Because of the scarcity of OTs and speech and language pathologists, we have very few OTs and speech language pathologists, so they will consult to various teams as needed. So this is how our teams for each block are composed. There might be there might be between 3 and 5 CRWs, depending on the size of the numbers of children. So typical teams. So again, the essential components of communication in our teams are like the respect for the parents, that they're the authority for the goals on their children. And always listening to the parents and getting their guidance and the exchange of information, collaborative teamwork, and collaborative teamwork with the family, with the CRWs, and within the therapist's therapy group. So always working very closely when they plan the assessments and renew the goals and the interventions. So for those who are not so familiar with the EI model, once children are screened and are identified, we have the assessments that are done by the CRWs and rehab specialists. And then goals are developed along with the family's priorities and goals. And then the intervention happens in the child's home, in person, or in COVID times through tele-rehab. And I will explain further the model. Children are gradually reevaluated every 6 months, and there's a reset of treatment goals and treatment plan, and the cycle continues, and everything is documented in the EI app. So just for further details, I'm going to come here. So the first step in the journey of the child and family is that we have an ICF-based child and family assessment. So that's the point of entry, is that we've developed a family-friendly assessment of questions that the CRW covers, that covers every domain with the family. And it looks at body structure and function, all the functions that the child does, how the child participates, their environment. And it's the introduction to getting to know the child and family. Next, we have the rehab specialists who will do their standardized evaluations in their own domain. Now, in the transdisciplinary approach, sometimes you may have group assessments, team assessments. Now, what we have here is we have separate, each therapist does their own separate assessments, but then gathered together, the information gathers together, and they discuss it as a team. So here we will have, depending what the primary impairment was, if following the first assessment, a motor impairment is identified, then it will trigger physiotherapists will follow the child. If there's, for example, a communication impairment, then speech trainer will follow. If there's intellectual, visual, auditory, and so on, then we will have the special educator follow the child. And also the primary therapist will be identified following the first assessment. So those identified domains will be followed by the rehab specialist. Next, we meet with the family, and this is where the primary or lead therapist meets with the family to discuss their priorities and goals. And that's where the goals that are identified there will be the goals that are transdisciplinary goals. There'll be goals that are not specific to one discipline, but just participatory goals that the family has and wishes their child to be able to do. Then we develop intervention plans and activities, and that's for all therapists and CRWs. And finally, we have family empowerment groups, and we have tele-rehab and WhatsApp outreach and peer support groups. So just to show you the different specialist assessment that are done, we have physiotherapy, special education, which includes the autism and ADHD assessments, communication assessment done by the speech trainer. We have functional vision and functional hearing assessments, and those are done by the special educator. And finally, we have the environmental assessment, which is done by physiotherapy, looking at whether or not there should be environmental modifications. So just quickly, that the COPM is what is used to identify family priorities and family goals. It's a tool that's being that was developed in Canada, but is used around the world in 40 countries, translated in 35 languages. So it's really looking at things that the child must do, wants to do, or needs to do throughout the day. It's going through a typical day with the child and seeing what the family wants the child to be able to do where the child is unable to perform at that time. And families identify their priorities. So everything that in our assessments, treatment, goals, everything is based within the ICF. So, and ultimately, what we want is we do not want to work at the body structure and function, just looking at the impairments or looking just at what we need to fix of the child, but we want the child to be able to function better for everyday activities, and even more so for participation. So this is really the best outcomes, is if we can have participatory goals. So participatory goals is being able for the child to be involved in meaningful life activities and functions, things you must do and that you enjoy doing for every day. So, and where we often can make changes is in the environment. We need to look at the environment. The environment can be either a barrier or facilitator. So just to give you an idea of where our goals should be and what level of the ICF we work. And this crosses any discipline. This is transdisciplinary, a transdisciplinary approach, where all we look at is for the child to be better functioning and participating and being inclusive and in every aspect of their life. So that's the holistic way to look at the child. So, and for those who are familiar with this is a lovely depiction of how the ICF framework and the F words, which will be covered in a later webinar, for children, where we have body structure and function, are fitness, the fitness aspect of a child. And the activity is everything a child must do for their everyday function. Walking, sitting, drinking, eating, all the ing words are in this activity and function levels. And then participation, friends, everything that is involved in meaningful life activities. And we make parents think about these various aspects of life when they develop their goals. Finally, there's the context here, the environment, and the environment of a child is the family. That's where they are, and everything that we can modify in the environment to enable participation. And finally, the personal factors, what motivates the child, what the child enjoys doing. That's where we want to look at goals. So here's just an example of how we individualize interventions and service delivery for various children. And these are just examples based right now on some of the children that we may see. So let's say we have Kartik, and Kartik is a young boy with cerebral palsy, and he may be 3 years old right now. So the lead in his case is that the physiotherapist will be the lead or primary therapist, and physio will go twice a month to visit Kartik. The CRW will also be going twice a month. And then we will have monthly joint visits of the physiotherapist, special educator, and speech trainer, who will work together to provide the best strategies to the family and to the CRW on how to achieve the goals. We also have an OT that consults, and then the team will meet once a month for an hour to discuss how to best achieve the goals for Kartik. We have Nisha, who has hearing impairment and has just received hearing aids. So because Nisha has just received some hearing aids, Nisha is followed more often. We've increased her frequency, so 3 times a week visits with the speech trainer. So because there is an increase in those visits, Nisha is being seen just twice a month at home with the CRW. And we will also have twice a month joint visits with speech trainer and special educator, so that the special educator can provide some feedback on how to best approach different goals. And SLP will consult and team meets to discuss once a month. Finally, Muthu, who is on the autism spectrum disorder. The lead for Muthu is the special educator, and Muthu is being seen at home every week by a CRW, but then is being seen once a month for joint visits by the therapist, special educator, and speech trainer. So what we have here is that the therapist will visit less often, but they will provide training to the CRWs, and it's the CRW who then coaches the families in the home. So just an example of different types of service delivery. So let's look at this case of Seva. So Seva here, he's an older one with cerebral palsy, spastic diplegia, GMFCS level 3. So he uses a handheld walker to walk, or right now he's actually using a lot of the furniture around the house, manual abilities. He does have some able to use hands, but with some fine motor impairments, and only mild impairment of speech and language and mild impairment of cognition. So his primary therapist is a physiotherapist. There's also a special educator who follows him, and there is an OT, but OT is also just consultative because there are very few of the OTs, and speech trainer is just consultative because his speech and language is coming along very well. So let's look at parent identified goals using the COPM. And for him, it was a lot of personal care goals, so ADL. And again, the lead therapist or primary therapist for Seva is the physiotherapist. So parent goals were eating. So their goals were that Seva would sit steadily and eat food with his hands without spilling. For dressing was that he would dress himself independently for upper body clothing. Toothbrushing, that he would brush his teeth and clean his mouth with minimal guidance and assist. Toileting was that they wanted him to walk using a walker to access the toilet on his own and use the toilet and clean himself with minimal caregiver support. So just thinking of that, we were thinking of the environmental adaptations that were needed. He needed clothing modifications to help with dressing. A lot of his clothes were too tight and needed sometimes something that they were more open, more easily put on. For toileting, and I will show you pictures, a ramp was needed for access out of the home, because there was one step, and to the toilet, and a wall bar adaptation was needed. For toothbrushing, he needed the use of a low bench to sit on. Here, the physiotherapist and the special educator who were actively involved would do a lot of discussion over what are the best approaches to achieve these goals. And the physiotherapists and special educators were working with the CRW, who was working with the parents to try to achieve these at home and coaching the mom at home in how to best help her son. He also needed some assistive devices, which were ordered, were new AFOs and a posterior rollator. So let's look at right now a few pictures here. So we have the eating goals. So he was able to eat food with his hands, with spilling of food on the plate, but he was able to eat some solid foods without any difficulties. So the goal of the parents was that he'd be able to finger feed without any spilling. Now, different problem-solving approaches were used to see if he would be better sitting on the floor, sitting against a wall, using the environment to provide the trunk stability. They tried a little bench to see if that was best, and trying to guide him on, which hand to hold on to the plate, if it was best with a spoon or with his hands, and which side to use. So a lot of problem solving with physio and special educator, and the CRW training the parents on how to encourage this on a daily basis. For the dressing, he was able to undress his upper body with minimal help, but the goal was for him to be able to dress himself. So again, he's sitting on the floor, and you could try him against the wall for stability, but sometimes it prevents movement. So he felt he was able to sit and move his arms best way he could. Different strategies were used, and there was a lot of problem solving. So the physiotherapist was able to consult with the OT if she had any questions regarding how best to approach the dressing strategy. Special educator was able to identify the different steps that were needed for him to understand the different sequence of the approach. So everyone was contributing to the goal. Here we have the toothbrushing. So we can identify the step-by-step approach that he took. So he was sitting on the bench, holding the brush, but the caregiver, his mom, had to put the toothpaste on the toothbrush that he needed help with. He was able to brush his teeth. And then after brushing, he was able to hold the cup and with the water to wash his mouth, but he needed some support. And it was found that sitting on a bench in the bathroom was the best approach. Lastly, the environmental modifications that were needed were to address the step that was at the door for him to be able to use his walker to get out of the house. And again, the step that was at the entrance to the toilet. So those steps were really environmental barriers that needed to be addressed. So a lot of environmental modifications needed some problem solving. So ramps needed to be installed for him to be able to walk out of the house and go out and just access the outdoors and visit his friends with his walker, and also to be able to go to the toilet. And they also needed to install a wall bar at the bathroom to be able for him to use the toilet and to clean himself after toileting. So if we look in summary at how we were able to work out the transdisciplinary approach with Seva and throughout the program, as I described, is that we have excellent, really good team interaction within each block. All the teams that work together really are able to interact on a regular basis, and they're really committed to teaching, to learning, and collaborating across cross their disciplinary boundaries. So they plan and they integrate services to try to meet those goals that have been set by the families. So it's really trying to develop the best strategies possible. Next is that the communication is that there's that regular sharing of information and to teach each other and to learn across disciplines. And there's consultation when it's needed. And sometimes consultation can be in a formal meeting or it can be just informal. When sometimes you just cross each other or you spend time together and you discuss certain issues. So it's a sharing of expertise. And it's not being defensive of your own discipline, but really recognizing that it's really the sharing for the best of the child and looking at the child in a holistic way. And then the child and family plan, it's that the staff and the family develop the plan together based on parents' goals and priorities, and also based on the functional assessments. And the family, again, family-centered care, the family is an active member of the team and they're involved in the decision-making. And lastly, the implementation of the intervention is that the primary therapists and the CRWs are the ones that will be most often in the home with the family and that use the coaching approach with the family. And then that's an empowerment of the family to be able to support their own child and actually to be able to integrate everything that they need to work on within the daily routine. And the more they work on the goals within the daily routine, you will get the best outcomes possible. So this is how we've been able to achieve successful transdisciplinary approach. And I will pass it on to Franzina to finish our session.
All right, so we are at the end. Just a few things to keep in mind. The whole emphasis on transdisciplinary care is to allow the child to receive efficient intervention that's cost effective, that is family centered, with less confusion, no duplication of services, and hopefully holistic services provided to the child. And it also allows for skill development and knowledge translation among peers and other professionals. So the take-home messages for you as a group and for parents and families attending today would be for clinicians. Remember that you are knowledge brokers, so you have to raise your skill level in terms of what you understand of the diagnosis, of possible effective interventions that could be made, and thinking outside the box to make the most efficient decisions for therapy. Your client is your primary goal in terms of providing services. So you need to be mindful of what they want for their child and how to best achieve that within the resources that's available to them. Always remember what's available. Try and keep it as family-centered as possible. Provide as much coaching and support to the family as you can through videos, through demonstrations. So like I said earlier about resource settings, Marie has already given you a bunch of examples, so keep those in mind as well. For children and families, identify, please state what your goals are, what your priorities are to the therapists that are part of the assessment. Write things down if you need to. This helps with creating a better treatment plan for you. You are the primary, so the goal of the therapist should be to empower you to effectively perform the therapy and encourage your child to, participate within the environment. Ask questions, ask for demonstrations if you don't understand things. and try and practice the skills, incorporate them within your daily routines as much as possible. Thank you so much for attending today. These are some of your the references that we've used today. If there is any there is a feedback form that we would request you all. Kalyani, did you have something to say about that?
Yeah, we have shared the feedback form in the chat box itself, and we will share in the mail also. And thank you, Franzina ma'am. Thank you, Mary. And other participants, if you have any other questions, please. This is our question answer session. If you have any questions, you can ask now. And one more thing here, our secretary, sir, Mr. Shankar Raman, sir, also here. Sir, please give me. Can you please give some words, sir? Hi, sir.
Yeah, it was an amazing and wonderful presentation by both Franzina and Murray.
Thank you.
Fantastic. So I look forward to the questions from the participants so that the session will be more meaningful and will reach our goal of an idea of making our people in India to understand the importance of doing the early intervention, because most of them would already be doing it. But how much it is important given the conditions, the constraints, and the challenges we face in terms of the limited resource settings in India. So I would like to see how the participants are responding and what their questions are, so that it becomes more empowering and meaningful for all the people here. Thank you.
Thank you.
Thank you, sir. Thank you so much. Yeah, participant, you can ask your questions now.
Hi, can I go? I'm Shabnam Rangwala. Hi, can I?
Hi.
Yeah. Hi, thanks, Marie and Franzina. I'm also an occupational therapist and enjoy working in low resource settings. So my question is the convincing the COPAM, even I've tried to use it with families in low resource settings. How does one really, I mean, there's so much in that medical model. They so want to just fix the child, ki child chalna chahiye, bolna chahiye. That is their goal. How have you all used to convince families, to look from the other angle? They at times think that, they are just passing on, this professional is passing on everything on to me. That feeling also comes. And using actually the two parts, the grading of the COPAM also. So if you could just...
Sure. So Marie, I'll probably just address the first part and maybe you could talk about the COPM after. Hi, Shabnam. So thanks for your question. So I feel fairly passionately about what you just said. And what I've tried to do as a clinician is break it down into very basic 5 activities that I would like you to do, and then translate this into how it's going to impact function and participation for the child. If you do X activity, you will see a difference in A, B, and C. And, I need you to do it 5 times a day. It could be, very basic activities to start off with. And you're actually selling them the concept of trying to implement this like a medication every day, 3 times a day through different activities. You're giving them options and basically making it very concrete in terms of what change you'd see because you're doing just these few things initially. Very often what I've seen is the parent comes back saying, oh, it's not like 100% change, but we're definitely seeing 15% change over the past 10 days. So what do we do next? So I think that's the opening.
Yeah, once start seeing the change, then yeah. Okay.
Yeah. Maria, did you want to continue?
Yeah, thanks, Francis.
Yes, exactly. And that's in my mind. I always tell myself I will give them so many ideas of, and like you said, maybe 5, could be 4, and to just add on to that, layer onto that, what you presented, Franzina, about for parents to have a video often of their own child, which you can create that video when you're with them, of the child doing that activity and guiding them and really demonstrating. And I find that oftentimes parents themselves will ask me, can I take a video of, you know, you showing the child how to, or me showing, like they ask to have it documented. And sometimes they want to show it even to Appa and to, but I think that's the best approach, is if they have something that they can replicate. And I just tell them that that's what child development is. Child development is having to repeat and repeat and repeat that skill over and over again. And the more you repeat, the more the child will be able to gradually learn. And you best learn when it's done within a natural occurring context, within the daily routine. And I always make parents think of, when is it that you could be doing this? And, you know, and I try to put them within their context of their daily life and their daily activities, and try to integrate it into their day. That's.
Can the parents distinguish between the 2 ratings in the COPAM? That is the how well the child does the activity and how satisfied are you? So that's where I, you know, get confused.
Yeah, for the COPM. Yeah, for the COPM. Yeah. Yes, yes. I tell them, yes, because there's performance rating and there's satisfaction rating.
Correct. Yeah.
So it's really how well, so if their goal is for their child to be able to dress himself, or yes, or it could be any type of goal. I ask them, how well do you feel your child is doing that right now? Okay, rate from 0 to 10. And it's very subjective. Some might say, well, he's doing it really just a 3, like not very well. But it's what matters. It is how parents feel subjectively about how well the child is doing. And then how happy are you?
Yeah.
So the satisfaction is, how happy are you with how your child is doing that? And even if their child's dressing a performance of 3, they actually might say they're satisfied, they're happy to 8 on 10. They're very happy of how their child's doing, because they know their child is really trying hard and has difficulty, but is doing quite well. So sometimes satisfaction and performance might not be hand in hand. And sometimes a child might be performing and walking like 9 on 10, but parents are never satisfied because it's not normal looking, you know. So I just say, how well is the child, do you feel your child's doing, and how happy are you with how the child is walking or doing the activity? Yeah.
Yeah, I mean, unfortunately, I haven't had that experience. I've found them rating both the things as the same. So they think of both the questions as the same, considering their understanding level. Then we are translating it into another language when you're communicating it to them.
So you have to have different keywords to use for the satisfaction. I don't say how satisfied are you. I say how happy are you with how, you know, how do you feel about how your child's doing? And then for the performance is, how well is your child doing? And not how is your child performing, but how well do you feel?
Yeah, maybe some
you just have to have simple words. So, but it takes practice in how to propose it, but we can address the COPM actually on future webinars, because I've applied it a lot in different contexts. Yeah, thank you.
Thank you. Thank you.
Other questions?
Can I?
Yes, ma'am. Yes, please.
So thank you so much. I'm Kripa. I'm a speech therapist by profession, and I work in 2-3 different settings, which includes a special school where we have a multidisciplinary, where we have a transdisciplinary, and another place where we have multidisciplinary. So one issue that we generally see sometimes is, irrespective of what model we are following, sometimes there's difference in opinion among the professionals. Like, for example, like ABA focuses a lot on reinforcement and all, and there's this hand-in training which most SLPs will be familiar with, which focuses on naturalistic approach. So when we work in a team like this, so how do we come on a common point? Because parents should get a message that, professionals are on a different page.
So Marie, I'm just going to talk for a minute and hand over. Hi, Krupa. Thanks for the question. So as a professional, I think if you are the lead therapist, right, we are creating best strategies for a home plan to encourage performance at home, right? So if you have been identified as the lead therapist, it is your prerogative as a speech therapist to identify those goals best and what interventions might suit the child, for sure. But simultaneously, if you are working with a physio and an OT as well, they might provide you with simplistic activities to help enhance what you are providing the child with. And again, this is knowledge transfer. I don't think it is an Indian issue or a Canadian issue or an American issue. This is a person issue, right? So I think building up skill across all types of professionals for a topic, right? An OT is not going to practice as a physio and a physio not as a speech therapist. That's not what we're suggesting by any means, but simplistic activities that you could suggest for hyperactivity is what you would expect the OT to provide you with, so that you can have better services provided as a result of it, right? At home, within the environment. So I think building up skill level as a group and maybe education across the board would help a bit. I'm sorry, Marie, did you want to add to that?
I just want to say, like, divergence of approaches or divergence of thinking needs to be dealt with separate from in front of the parents. You don't want to start having like discussions in front of the parents. I think in any setting, whether you're in India, rural, urban, in Canada, anywhere, you really need to have a team meeting separate from the family and get your strategies aligned. You have to be aligned as a team. And I think once you're aligned, and also the lead therapist is the one that really is the one that should take the lead in terms of best practice. And if you have diverging opinions, it needs to be dealt with separately, because family-centered approach is the team just discusses their differences separately, and everything is just for the benefit, what is best for the child and family. So what you present when you are with the family is what you have decided upon separately. So I just feel that that's, yeah, because everywhere around the world, there will be diverging opinions. And the worst thing is if you come in front of the family and they see there's tension of different approaches, and yeah, that's thoughts on that. Yes.
Thank you. Thank you so much. I just also wanted to add about this previous discussion about videos, taking videos as models. And so we do that quite a lot in our practice, and we see that works like magic. And generally asking parents, did you try working this at home? They say yes, but when we ask them for a video, that's when we know whether they've really worked, it's translated to home or not. So video really works well.
Yeah, thank you for that feedback. So as a clinician, like you said, they do it and they have done it, is what you're saying?
Yeah, yes.
That's great. Thanks.
That makes a lot of sense. Thank you so much. It was a wonderful session and very informative and very practical. I think, just unlike many sessions, sometimes becomes more theoretical. It was packed with so much of ideas. Thank you so much to the speakers and Amar Seva. Thank you.
Thank you so much. And for the video, I say like, I like to make a video with the parent, well, either with their cell phone of when you're present with them and as a learning tool. And then what I tell families is for them to take a video. So next time I see the child, and also they can send the videos, and I also what they can take a video of the child doing the skills at home. And what I have sometimes is I have a family sending me a video saying the child's now doing it on their own, and they take a video and they send it to me, you know. So it's an interchange of videos. And right now with the COVID times, and we're doing more tele-rehab. We're doing tele-rehab at Amar Seva now instead of in-home. And families are taking videos and sharing with the therapists for the tele-rehab. And that's how they're sharing back and forth of how the child's progressing on the goals. So yeah, a lot of interchange of documenting the progress. And yeah, thank you. And we welcome you to join us. We're going to have monthly sessions till June. We have scheduled the end of every month. We're going to have different topics that you can register for. We also have 2 months that will have management, NGO management webinars. So yeah, and so if there's
you'll get information about that, right, Marie? They'll have emails.
So if you can fill out the feedback forms, we'd really appreciate your feedback, and you'll get an e-certificate sent to you. Yeah. So we will.
All are requested. We have shared that feedback link in the chat box. All are requested to fill that. Then you will get that e-certificate. And once again, I am thanking Marie and Franzina for this wonderful session. Thank you so much. I think Marie is attending, giving
it's 1 a.m. right now here in.
You are from Canada. This is 1 a.m. Yeah, thank you very much, Marie.
Welcome. Thank you, everyone. Yeah, thank you all. Have a nice day.
Thank you all. Thank you.